principles of screening as well. I mean, Hep C's got
So, just picking up where we left off before lunch with surveillance and reporting, we discussed the fact that there was not a...
Just one moment. Yes.
We discussed before lunch the fact that AIDS was not a notifiable disease, HIV not a notifiable disease. And I think it's right to understand both from your report and the evidence the inquiry's heard that meant that other voluntary mechanisms had to be developed, and in relation to AIDS, it was the CDSC under Dr. Galbraith who established a surveillance system in the early 1980s. And again, that was a voluntary system, is that right?
Yes, that's correct.
Just then more generally, do you or any other members of the panel have any understanding of the role that death certification plays in surveillance?
Well, it does play a role in surveillance, but that's late in the day, of course, and it also helps establish risk and mortality, especially if you link it to when the disease was diagnosed, survival times, etc. You might want to add to that, but yeah.
And are there any systems or processes in place to ensure that death certificates accurately record the contribution of, for example, an infectious disease?
I think this is your question.
Yes. No, the death certificate will record a number of different causes of death, and which is given priority is up to the person who's filling out the certificate. So everyone at the end of their life dies of cardiac arrest. It's the common thing. That might be the top, but what is underlying that is the question. And I think that will vary from clinician to clinician, what they put in. And there probably are fashions with what goes on the death certificate. So I think for a broad brushstroke of what are the things killing people in the UK, they're very valuable. But for very detailed work, they're a bit too coarse.
And is it your understanding then that it is down to the individual clinician as to how they record the causes of death?
Yes, they will record it according to their own views, and then there are some coding rules that OPCS will then implement, maybe to reverse some of the causes on the death certificate.
Yes, and in fact, the individual GPs may in fact be phoned up. So if you just put old age down, for example, you may get phoned up and questioned about the underlying causes as well, or whether that was actually the cause of death.
Could I just add something in relation to death certification, because it's become an issue, not so much in relation to HIV, AIDS or hepatitis, but in relation to COVID, in that there are systems for how you record things around mortality data, whether you go to the WHO mortality approach or whatever, but also it's up to countries as to how they can determine that in terms of what they want recorded as well. And the UK, particularly in England, sort of struck out on its own in relation to that. So I think death certification can illuminate quite a few things for both surveillance purposes, but also for the politics of managing infectious disease, and we need to be mindful of that.
But in order to do that, does there need to be a degree of consistency and accuracy in the way in which death certificates are completed? And just so the panel understands the context, this inquiry has heard, most recently last week, of deaths that were unquestionably due to the HIV virus, in which neither HIV nor AIDS features in any part whatsoever on the death certificate. And that presumably undermines the role that death certification can play in surveillance.
Yes, of course, there should be a degree of consistency and standards, etc. But also cultural and societal norms can come into play. So, for example, the recording of suicide often wasn't actually recorded on the death certificate for obvious reasons. So I think it's like all of these things that, it really needs a deeper drilling down to understand the context in which these certificates are being written.
And then can I ask you to look at... it's an article referenced in the report. It's at RLIT 0001748. It's called Giants on Clay Feet, and it's a detailed argument which looks at the response in the context of the COVID-19 pandemic, the response and indeed the history of elements of public health decision-making in England and the US and then in Germany. I'm not going to go through the detail of the report, but for those who want to have a sense of the history of the organisation of public health certainly in England, there's a very good description in this article. But if we could just go, please, to page 6. There's just one sentence I wanted to ask the panel about. And it's the first sentence on this page. Public health has always stood at the crossroads of politics and science. And my question was as to whether the panel could help us understand what's meant by that and whether the panel agrees with it. Professor Farrell?
Well, oh, sorry, I thought David would have his hand. Yes, I think that's, I would agree with that statement. And for example, when under sort of my, I worked on question 18, for example. So if we're looking at the management of risk, and perhaps even a precautionary approach to managing risk. The question can be, first of all, what sort of scientific expertise are you gathering in to assess the risk? But ultimately what you're doing with that expertise and the data that you assemble in that regard in terms of making decisions about that. So precautionary principle, for example, highlights the fact that you need to consider risk assessment, risk communication and risk management. And that brings together science and politics because ultimately risk management is a political decision. So you get your advice in, and when you're managing a population level public health risk, there is this intimate relationship in this regard. But there are debates because there are different forms of expertise at stake in terms of science and medicine, as well as political imperatives as well that may impact upon trade, upon individuals and at the population level. So yes, and that's well identified in the literature, often highlighted in the context of the precautionary principle.
And just before we move on to discuss the precautionary principle, no, not at all. It's the perfect segue to the next part of the questioning. Just before I ask you a little more about that, are there any other observations on this interrelationship between politics and science in the context of public health? Professor Pollock.
Well, I can only give you my view of it, which is it's really, public health has always seen itself as an advocate of the people, as in the Ibsen play Enemy of the People. Much of public health is socially determined, but these views are often not popular. This analysis is not popular, the social determinants of health, the effects of poverty and ill health, housing. And so it's really being able to speak up and speak out about issues, and that's often deemed political with a small p. So that's how my own view of it.
Professor Armstrong.
I think a lot of public health is involved with either constraining or influencing individuals, whether it's quarantine, where you block people, or just advising people not to smoke. So there's a whole range of ways you try to affect people's behaviour, and that, of course, is a political issue, should you.
And then just before, I want to ask a little more about the precautionary principle. Just before that, we've discussed at fairly swift speed the decades of development in terms of the structures for public health decision-making in the United Kingdom. What do you make, and I'll direct this first to Professor Pollock and then to others, of the current ability of the system to react very swiftly to an emerging risk?
Well, as I explained before lunch, the system as it was put in place has been eroded and now dismantled. So I would say that we can have very little trust in the current system because it's heavily centralised, but the funding, the statutory powers and executive powers no longer rest at the local level. And indeed, there is no local level because now what we have are these huge integrated care boards, 42 of them, We no longer have any health authorities, and local authorities no longer have the executive powers or responsibilities for infectious disease control. So I would say that the system is absolutely dire, and it's in need of rebuilding, and that's why we've made a recommendation around necessary legislation in this report to reinstate the NHS and the systems for communicable disease control.
Any other contributions on that issue?
I think the systems in place depend on the level of risk that's perceived. I remember, was it 50 years ago, there used to be nuclear bomb shelters built under houses because there was a fear during the Cold War of a nuclear war. So people were aware that that risk was there, so they did things about it. I think the COVID pandemic has changed that, and now people are aware that infectious diseases are much higher risk. But in the past, they didn't think that that was so, and therefore they allowed all these systems to be denigrated over time. But I think we're now in a new era where infectious diseases we now know that they are very risky, and one will follow another.
Can I just add, we know that, but the evidence for this inquiry shows that the workforce capacity isn't in place, nor is the system. So that will have to be reconstructed if we're going to be able to deal with future infectious diseases.
Yes.
And then before I move to discuss the precautionary principle in a little more detail, are there any other observations from the panel on the matters that I was canvassing with Professor Pollock before lunch?
There is something I'd like to ask, though. And it's this. In particular, you, Professor Pollock, have stressed the importance of surveillance and surveillance at a local level. That's surveillance of the consequences of some infection or some health challenge. So the infection or the health challenge has already got to be at the local level in order to be recognised. How does the A system, this is talking generally as opposed to discussing our system, how does A system cope with a disease which is not here, as far as one knows, yet, but is emerging somewhere else? One may think of diseases such as SARS or Zika or HIV when we first became aware of it emerging in the United States. That's something which may cause problems, not least because of the very long incubation period in some such diseases. How does one control that? At the ports, or how? How does public health respond to a disease which is emerging not here, but there?
Well, I think the first thing is good information and communication. So that is the important role of the WHO, the World Health Organization. And then, of course, the regional departments of the WHO. And then you've got the European Centre for Disease Control, but you've also got the Centre for Disease Surveillance and Control. So that's really very important that you have a national alert system that is then capable of feeding down to the regions and to the local level. The problem is we don't have the regions and the local level. I don't know whether I'm answering your question or not, but that is really important if you have warning, for instance, of HIV and AIDS. That warning was put out by Norman Galbraith in May 1983. The question for me is, why was that not acted on, and how far did that information flow, apart from through the scientific journals or through the infectious disease clinicians?
Does anyone else have any observations on the question that I've asked? How do we here respond in public health terms through a system to a disease or infection or possible disease or possible infection which is happening not here but somewhere else and may, given the ease of travel these days, be transported or transport itself here?
I would like to add something to that. If we think about when HIV and hepatitis and infected blood products were occurring, you're also looking at the need for, when infectious diseases occur elsewhere, there needs to be an interdependent trans-jurisdictional approach to managing that risk because, as Atchison said in his report, it recognises no jurisdictional boundaries. What you had during the sort of closing decades of the 20th century, and I'm not saying this is the ultimate panacea, but you had international health regulations that were outdated, that couldn't manage a whole range of infectious diseases and organisms. Now, they were updated in the first decade of the 21st century. It also strengthened the WHO, the World Health Organization's powers to gather information about what was going on about the spread of new diseases, to declare public health diseases of international concern, which they did with COVID back in March 2020, and galvanise both local, national and international responses. So while I don't say that the law and regulation can solve everything, it provided the basis for enhanced powers that were not present at a trans-jurisdictional global level to counteract a range of infectious diseases, and particularly strengthen both the relationship between public health and trade, but also public health, human rights and international action to address infectious disease that could be acted on at local level.
And the follow-up question really to things happening there but not here, how does our system react to something which is emerging, let us say, in Northern Ireland or in Scotland or in Wales or in England, but not elsewhere yet, at any rate, in the devolved nations or the home country, as it were, if I could call it that, England?
Well, it often begins with case reports and medical journals and the clinicians communicating and talking to each other. So HIV and AIDS was one very good example, and people attending meetings and learning about things. And then that's one way in which this is actually understood and spread, certainly in the clinical community.
So this isn't a public health system. This is relying upon those
At an
people
early
in a particular
stage,
specialty.
early stage when the disease is not sufficiently understood or known about. But are you talking about diseases that are well understood and known about? No. So at an early stage, it's usually case reports, which then go into journals and presentations and discussions and scientific meetings.
Yeah.
And could I add to that in the case of within the UK? Of course, the UK isn't an island on its own. Managing collaboration, as Anne-Marie was saying, in terms of international cooperation with Ireland, so that you've got clinicians across the archipelago that are able to communicate effectively with each other to spot emerging issues.
If I may, I mean, I'm sitting here thinking, how did the pandemic fit into this?
Yes.
I mean, we do, after all, have a government which ought to be scanning the environment. We do, after all, have scenario planning exercises. It is yet to be seen whether or not the scenario planning exercise which anticipated the pandemic was acted upon nationally as effectively as it might be. So I think national government does have a responsibility for keeping an eye on developments and actually having in hand contingency plans for reacting to the sort of situation you are talking about. I don't think it's, in this case, just a question about getting local information and bringing it together. What you're talking about is how good are the scenario planning and contingency plans in government to deal with that kind of situation. I think at the moment we've got cause to ask questions about that.
Well, just in the context of the pandemic, it was well known, many of the issues around COVID, who were the at-risk group, who was most at risk, a lot from the report from China that the WHO brought forward in mid-February. So the question is, why was the WHO not stronger and more able to mobilise the closing down of borders, etc., and why did governments not respond fast enough?
Well, that question
will be a question
is
for the COVID
just as
inquiry.
well. That's for another inquiry.
Yeah. Absolutely. Coming soon.
But the general issue is certainly allied to that.
And just, sorry, Ms. Salters.
I was just going to say that, coming full circle to your question earlier on about that sentence about public health standing at the crossroads of politics and science, that COVID provides that sort of example. At what point is it right to shut down a country? What's the critical stage? How do you balance infections, capacity of the health service, risk to the economy, infringements of rights? That's a political decision when you intervene. We can debate whether the UK got it right or wrong on that, but it's a political decision based on emerging science, but also juggling of a number of factors. And public health is the process of how you take those difficult decisions in the real world with the background of science and the context of us all trying to live our lives and run our businesses in that world.
Just in terms of the international dimension, it might be worth noting, if we go back to the Liam Donaldson report, so RLIT 0001745, and go to page 101, under the heading Department of Health, there's a description of the role of the Department of Health, in particular in relation to infectious diseases in England, and we'll come on to this when we look at the devolution issues, but it may well be as equally applicable to the respective governments and departments in Wales, Scotland and Northern Ireland. But there's a range of responsibilities there set out falling at national level, and if we go to the bottom of the page, we've got the reference 4 bullet points up to horizon scanning, maintaining an overview of infectious disease trends and patterns, and strengthening policy and action where necessary. And then the bottom of the page, contributing to an effective international collaboration on infectious disease prevention and control, including surveillance, international regulation of travel and travellers' health. So I thought it may be useful just to draw attention to that. So if I move next to the precautionary principle and its role, and I'm going to direct these questions primarily to Professor Farrell, but then again ask for contributions from others. You set out in your report, so if we go back to the expert report, please, Lawrence, internal page 14, so I think page 20 probably. Yes, so the definition, you say this: the precautionary principle was originally developed in the 1970s to address risks to the environment, but was subsequently expanded to also encompass risk to public health. The principle requires that, and then the quotation is, proactive action be taken to prevent or minimise threats to human health or the environment, notwithstanding the absence of full scientific certainty about the nature and scope of such threats. Now, that's a definition drawn from your own book, Professor Farrell, which is The Politics of Blood, Ethics, Innovation and the Regulation of Risk. But I think it's perhaps important to note from your book, and it's page 168 of your book, that you've drawn that definition from a number of sources, including the Rio Declaration and statements on the precautionary principle from other sources, including the Commission of the European Communities.
That's correct.
So it's a well-recognised definition.
There are differing definitions. What I was trying to capture there was to, putting them all together, what did we come up with in terms of a threshold or baseline approach? Yes, correct.
And in very basic terms, and if I'm oversimplifying this, please say so, but is it right to understand the precautionary principle in this way, that it requires builds in a proactive rather than reactive stance, and rather than wait for proof of harm, scientific certainty or even probability, you act in response to the potential for or possibility of harm. Is that right?
Crudely speaking, yes. Again, no doubt you'd find scientists or clinicians or people with particular expertise, statistical or otherwise, saying, well, we can debate what the baseline is for action in that regard. But the whole idea of being proactive rather than reactive is firmly centre stage.
And then you've identified 4 elements here in the report. So it's the paragraph beginning key elements informing. And these elements you've identified here: the taking of preventive action in the face of scientific uncertainty. So that is as I sought to summarise earlier, you don't yet have proof, you don't yet know that there's perhaps a causal connection between X and Y, but you think there might be, and the harm is potentially a serious one, and so you take action.
So you'd need obviously data and information and whatever research you could have to identify what the baseline was in terms of the risk that's faced, but there may be a lot of ifs and buts. For example, you may not have serious harm or mortality data that would inform the taking of action, but ultimately, in the light of scientific information and expertise, there has to be a policy or a political decision on when to be proactive.
And then the second element described there, the shifting of the burden of proof to the proponents of a particular activity to show that it is not harmful. Now, you've told us this is a principle that originated in relation to environmental harms. To what extent does that second element, this idea of the shifting of the burden of proof, is that something that translates into the health and public health field as well, or is that more in the field of environmental harms?
Well, look, I think you could debate that. Certainly, its origins are in the environmental domain, but you know, again, with a legal background, we can interpret burden of proof in all sorts of ways. Perhaps what we might understand in legal terms as burden of proof or balance of probabilities would be very different to how scientists would understand it, for example. That's why you need an understanding of burden of proof to initiate proactive activity. You need to bring together a multidisciplinary approach to understanding proof in terms of taking a precautionary approach. That would differ, I would suggest, although there's interrelationships between the two, between the environment and public health.
And then the third element you identify here is the exploration of a wide range of alternatives to possibly harmful actions. And that, again, that would appear to be something that it is very readily applicable potentially to public health and health decisions. The exploration of whether there are things that can be done. And in the context of blood products, for example, it might be treatment with something else or no treatment at all as opposed to treatment with a blood product. But whether there are things that can be done at that stage of scientific uncertainty which are likely to be less harmful.
Yes, I think that was a particular dilemma that arose in relation to, for example, HIV, less so hepatitis, but HIV contamination of the blood supply. When you're looking at a potentially catastrophic risk, which is what you were facing at in the early to mid-1980s and continuing on from there, is how do you address a catastrophic risk? And precautionary principle urges you to consider alternative treatments. It may not be, for example, if you're a person with haemophilia, that you either continue to take factor VIII product or you do not. But there may be an alternative to consider depending on your level of severity. Can you, although it may not be what you seek, switch to something like cryoprecipitate for a while? If you perhaps have mild haemophilia, do you switch to not treating if it's not a severe bleed, for example, or only occasional one? So some of the guidance at the time, particularly from, for example, haemophilia organisations, sought to deal with alternative treatments. I think in the blood context, you're dealing with the juxtaposition of public health management at the population level versus how you manage alternative scenarios and treatment in terms of individuals and what they need in terms of healthcare treatment. So it's not straightforward, but again, certainly the reports that followed an examination of HIV contamination of the blood supply say that that was a dilemma faced by decision makers in terms of a graduated response looking at a range of alternatives.
And then the last of the elements that are listed here is the need to increase public participation in decision-making about the use of precautionary strategies. Can you just assist us in understanding a little more about what that refers to?
Yes, it's, again, I see I've quoted Kriebel and Tickner there, so they're more focused in the environmental context too. But the whole idea that when you're engaged in a proactive approach and an appreciation that the management of risk can combine science, humanity and politicians as well, where do we fit the public in. Because they're the ones who may be facing the risk. How do we channel through their understanding of risk, both in an individual sense and a population sense, and how do we incorporate that? So that's what they're trying to get to there.
And then you say this: the precautionary principle should be considered within a structured approach to the analysis of risk, which comprises 3 elements, namely risk assessment, risk communication, and risk management. Can we just take those in stages, just to understand what's being discussed there? So risk assessment, again, it may be relatively obvious, but what is it that that's referring to?
Predominantly, it refers to scientific assessment of the risk, scientific and I suppose expertise in the particular risk that you're facing that would feed into an overall decision if you're going to act on the basis of a precautionary approach. Risk communication, normally that does refer to communicating with the public about the risk, but it can also be just generally understanding, if you're coming from different areas of expertise or different perspectives and experiences, how you understand risk, but it's about communicating that risk. And risk management would pretty much firmly be within the political domain, making a decision whether to act or not, based on all that information.
Now, it might be said that none of what's set out there, perhaps in particular the idea of exploring a wide range of alternatives, is rocket science. Does it need the label of precautionary principle or a recognition that there is this idea stemming from environmental harms and moving into the public health field? Do you need to call it that in order to understand that actually assessing risk, understanding risk, communicating it, considering alternatives, lies at the heart of good decision-making?
Well, I suppose it depends what you're talking about in relation to decision-making. For example, if you're talking about a doctor-patient relationship, of course, ethical principles and there are even legal obligations about disclosure of risk. And you nowadays, of course, you look at what the patient attaches risk to, and you involved in sort of information disclosure about risks in that regard. Now, around the 1980s, that would be perhaps more of a doctor knows best approach, but now it's much more of a partnership in that regard. When you're dealing with things at more at the population level, and I would defer to my public health colleagues here as well, is there may be a more a complex array of risks and also perceptions of risk that have to be taken into account. We do refer to that in the report as well. Where are you getting your expertise from? Because for some areas of scientific or clinical expertise, the set point for risk is different. But good risk management at a political and policy level involves understanding those different approaches, but realising your ultimate responsibility should be to protect the public.
And when did the terminology of the precautionary principle start to be consciously articulated in the context of health and public health as opposed to environmental harm?
Yes, I mean, I suppose my experience, and I need to say, is more in the blood area as to when that happened, and I would defer to Professor Pollock and other people as to whether it was used in public health more generally. I would say it was not prominent in terms of terminology that was being used when HIV, for example, emerged as a risk to the blood supply. But having said that, in terms of understanding the risk that was faced by people with haemophilia or those who may have been subject to blood transfusion, everyone was on notice that there was a significant risk, certainly from the end of 1981 into 1982 and then into 83 most definitely. And there's lots of policy makers and scientists discussing that. A lot of it was driven at the time, and I'm sure it's come out from North America. So there's lots of debates going on. So I think in some senses you're quite correct. I don't know that you need to label it, but there was awareness of a risk, but the trigger point for action. So if you're going to use something like the precautionary principle, it situates that trigger early and it becomes a policy imperative. And I think that's what began to change as you head into the late 1980s and early 1990s. By then, it's politicised as well. So it's the concept of look at the tragedy that we're facing. Do we need to just accept zero risk in relation to blood safety? That is a precautionary approach, and we can debate whether that works.
Ms. Richards, yes. I think Professor Vincent wanted to make a contribution.
Yeah, but I don't have to come in now.
No, please do.
I think in addition to what Anne-Marie is saying, it's quite useful to think of it, as you said, it's the precautionary principle in a sense is, you might say, well, it's not rocket science. And at this level, labelling it is obviously very useful for kind of getting people to take it seriously. But you could see it also, and very relevant to this inquiry, I think, is the whole business of how you manage safety. And you could see this as a much more, as part of the more general quest to be more proactive in assessing risks and so on. So, I mean, a good clinician, for instance, will spend time thinking about, yes, but what might happen, what might go wrong in this operation or whatever it is. And if you're in the oil industry and you want to set up a new installation, you have to make a safety case. You have to set out all the things that might go wrong, if you like, and how you're going to deal with them if they do. Now, this sounds a sort of, very common sense in a way, but it does demand a particular kind of attitudes. It demands, in particular, creating time and not just say, oh, we'll get on with it, we'll rush in and, it'll be fine, don't worry, And both at a personal and organisational level, it's quite a cultural shift to have an organisation of whatever kind, whether it's a children's playground or an oil company, that sits down and says, yes, but before we do this, we're going to think this through. And often there's a lot of formal methods and things to do. So this sort of general idea of putting safety first, if you like, and making that not only objective, but thinking that, yes, this what might go wrong idea, it permeates almost everything you're doing. So I would say the precautionary principle, I'm fully with what Anne-Marie is saying, but if you like, it's a special case of something that you need to think about much more generally, I'd say.
Can I disagree? I'm allowed to disagree with my
You are?
colleagues. It seems to me that there are many uncertainties, especially in public health, about the risks we all run every day of our lives. And those uncertainties, I don't see how they can actually cause us to have some sort of precautionary principle. So to give you an example, we know that probably, in inverted commas, that bacon is harmful, that it causes colorectal cancer in some patients, and every year there must be several dozen patients in the UK who die because they've eaten bacon. Now, should we therefore ban bacon? We know that people who drive cars are much more likely to die from road traffic accidents, which is a death. Should we therefore ban driving? It seems to me there's lots of risks we're all willing to run every day of our lives because the risks are very, very small. When the risks get bigger, then obviously we've got to start to act then. But usually with areas of scientific uncertainty, we're not actually sure at which point we pass that threshold. We move from very minor, trivial risks to very important ones. And I think that's the trick, is to know when to move. Implement the precautionary principle, but the idea itself can't be operationalised. We can't put it into action until we've actually looked at the particular situations we're in.
Might one of the examples you've just given reinforce the importance of the fourth element that Professor Farrell described, public participation and communication of risk, the idea of risk communication? Because your first example, the idea of bacon, consumption of bacon and increased risk of cancer, the obligation there may be to ensure that people fully understand that risk and therefore can take their own decisions as to whether it's a risk that they're willing to run.
But with respect, there are risk profiles for almost every food you can eat. And the uncertainty around everything, from coffee to tea to everything, there's a tremendous uncertainty around all of these things. Now, it's impossible for everyone to take on board all of those statistics, especially as they're very uncertain. So some reports say that coffee is bad for you, some reports say it's good for you. Now, which one shall we follow? Which one should we communicate to the public?
Professor Pollock.
I'm just going to return to infected blood, because, of course, the risks from infected blood have been known since the 1940s. And in 1950 or 51, the chief medical officer, in his annual report, was writing about the risks of infected blood and the need for caution when you're transfusing people, i.e., really it should be very appropriate and very considered. So the question for me is, how was that communication then communicated and used to inform the system and the clinicians working within the system? And I think we probably know there wasn't, because there's too much made of clinical autonomy. and not enough about the information around risk and the knowledge of the clinicians and understanding the risk and then communicating the risk. And that comes out very clearly again, because for me, why was there no action taken following Norman Galbraith's letter? What was it that stopped that happening?
And it might be said that the May 1983 letter from Dr. Galbraith that you referred to then and you referred to earlier, no one might have called it an articulation or application of the precautionary principle at the time, but it might be said it is absolutely that. It is a recommendation for action in the face of uncertainty.
Yeah, it is. Not uncertainty, there was knowledge. I would say it was cautionary, not precautionary, a cautionary principle that actually to take action to withdraw those products because there was enough information about the risks and the very high levels of mortality.
Can I just say,
yes.
I mean, this is a discussion which would interestingly go on for most of the night. I'd only observed two things as someone who's worked within government, although not within Department of Health. One, I found civil servants in particular very reluctant to involve themselves in discussions about contingency planning because policy was going to succeed whatever. So why do you need contingency plans? So it's not instinctive in the system to spend time, as Professor Vincent was saying, just thinking about what we do if these risks actually materialise. The second point is, and you'll doubtless come on to it when you're talking about patients and patient involvement, the instinctive response of government and civil service is not to involve people. It is actually to do things. And I think that's really quite dangerous. And when we talk about public participation, I'm quite suspicious, because that term, along with public consultation, has been used for 50, 60 years. It doesn't actually mean giving any sort of power to the public, to the citizen, to influence the decision.
And you're right, we will certainly be coming back to that. That will be a theme for tomorrow morning. Just again in relation to the precautionary principle, can I invite you to look at an article, again one referred to in the report. It's RLIT 0001752. So it's by Wilson, July 2011, a framework for applying the precautionary principle to transfusion safety. And it's really just a discussion about the distinction between evidence-based decision-making and precautionary principle-based decision-making that I wanted to ask about. So if we go to the second page, under the heading Problems with Evidence-Based Decision-Making in Transfusion Safety, so the left-hand column, we can see the discussion as follows. The precautionary principle represents a paradigm in risk decision-making, providing a mechanism to guide policymakers in areas of scientific uncertainty. At the time when HIV and hepatitis C were being transmitted to thousands of recipients through blood transfusion, decision-making in transfusion safety was largely being governed by a different paradigm, evidence-based medicine. Evidence-based medicine was primarily intended for the care of individual patients and was a consolidation of principles that had long existed in medicine and science. The movement reflected a concerted effort to standardise the approach to examining evidence and applying it to patients. Evidence-based medicine is largely governed by a hierarchy of evidence where randomised controlled trials are the gold standard and lower levels of evidence are believed to be more susceptible to bias or systematic error. And then there's the next paragraph essentially, I think, largely repeats what was set out above. And then we see towards the bottom of that column a discussion in the context of surrogate testing for hepatitis C of adherence to the evidence-based approach. And then if we go over the page, no, I'm sorry, Lawrence, I meant to say go to the right-hand column on the previous page. My apologies. So the top half of the right-hand column then refers to testimony in Canada, and if we pick it up in the last 7 or 8 lines of that paragraph, the result in Canada was a decision to forego surrogate testing until the results of a randomised controlled trial were available, which would ultimately reinforce the value of the tests unfortunately, the delay in implementing testing potentially contributed to thousands of individuals being infected with hepatitis C through blood products. And then there's a quotation later on down the page from the Crever report. Not asking for particular comment on surrogate testing or on the conclusions of the Crever report, but Professor Farrell, can you perhaps help us understand this reference to this idea of evidence-based decision-making as against the kind of decision-making that we've just been discussing?
Yes, I would almost defer, maybe Charles would like to come in here to talk about evidence-based medicine first and sort of how that was situated. Would you?
Yes, or David, but I think I can make the general point. I don't think, to my mind, I don't see it as a sort of in opposition to the precautionary principle. It's more as David was saying, and others. It's what you do when you don't have the evidence. And I think what they seem to be saying here, as far as I can make out, is that if people say, well, we should wait till the randomized controlled trials will be done, I mean, which is, there's nothing about evidence-based medicine that says you need to wait when, well, you can still get on an act. And so it's not as if there's evidence-based medicine versus the precautionary principle. It's when you don't have the evidence, are you going to be safety conscious and are you going to act in conditions of uncertainty of whatever nature that might be? And if you're going to act, then what are your kind of criteria and guidelines for, deciding to act or not?
Could I also just add, again, in the context of what was going on in terms of the emerging risk posed by HIV to the blood supply at the time, you've also got to take account of the fact that different scientific experts had a different understanding of what constituted evidence. So, for example, if you've got blood transfusionists, a lot of them might have a background in microbiology or pathology, for example. They would perhaps they'd want to see more, I suppose, robust data around morbidity and mortality, but also testing technologies would be extremely important in terms of looking at prevalence in the blood supply, for example, whereas you would have a range of other scientific experts who would look at different forms of evidence that would have meaning for them within their scientific subdiscipline. So it's important, again, that you have a robust approach, but also a multidisciplinary approach when you're dealing with a public health risk such as HIV.
Can I just add to this comment? I think it's easy retrospectively to say we got things wrong, but at the time I think there was a great amount of uncertainty. I tell you, nowadays we've got millions, billions of viruses in and on our bodies. Everyone in this room's got viruses. They're everywhere, in us and on us, and there are lots of viruses in blood. We know about A, B, and C, but there are lots of other ones. Now, will they, in 5 years, 10 years' time, be shown to be deleterious to our health? Well, we don't know. It's an area of uncertainty. So should we act on it now, just in case those viruses cause harm? So I think retrospectively we can look back and see that B and C were dangerous viruses, but at the time I think there was a great amount of uncertainty about how harmful they were.
Professor Pollock.
I want to come in slightly off tangent a bit, because one of the questions is to what extent was there money going into doing the research? And John Krask in 1983, he was the deputy director of a public health laboratory in Manchester. I think you might have taken evidence from him. He was looking into the possible association between AIDS and factor 8 or 9. It took a full year until September 1984 before the MRC and DHSS agreed to split the £28,000 required over 2 years for a slightly more open question. And then in 84, again, we find that Galbraith and his colleagues put in a bid for £120,000 for work on AIDS epidemiology. But in March 1985, they were only offered £7,500 for a study on risk factors. So we have to play into this. The evidence-based medicine is at high level, but to what extent was there support for the research that was so necessary into the causes and the association between blood and I apologise for referring to things that aren't in the report, but I thought this might help illuminate it.
No, not at all.
And we have indeed been examining, not from Dr. Krask directly, sadly, but we have examined in multiple hearings a number of his studies and pieces of research, and indeed the state of knowledge in relation to the seriousness of hepatitis B and C at the time. Just the last question in relation to the precautionary principle, and that's the role of issues about cost effectiveness. Professor Farrell, in the report and indeed in your book, you say there are differing perspectives
That's
about
correct,
the extent to which cost effectiveness has a part to play.
Yes, and I suppose when you, and there are different approaches in different jurisdictions in that regard. So in the wake of HIV blood contamination scandals, for example, in the United States, Food and Drug Administration would have argued, I mean, my knowledge is as up to sort of the first decade of the 21st century, would be that cost-benefit analyses should not come into the management of risk anymore, but you've got sort of a politicisation of risk at that point around blood safety. So that I suppose it determines how you approach new and emerging risks to the blood supply, but also, for example, what testing technologies you put in place in order to protect the blood supply. And for example, in the UK, you could also debate whether the set point changed in terms of how cost-benefit analyses were done in terms of blood safety. Do you keep introducing new testing technologies or adopting a highly precautionary approach because of the political fallout and the politicisation of risk that has occurred in the wake of the contamination scandals? So normally when you're looking at introducing a new technology, you might do a cost-benefit analysis. Particularly in a publicly funded health system. But in the wake of the fallout from these scandals, that was debatable as to the extent to which you applied that. And I suppose it picks up on what my colleagues are saying around how you manage uncertainty, how you manage the fallout from a failure to manage uncertainty or a perception of that, and where cost-benefit fits in mainly in relation to future risks. It's not clear to me from my research that in terms of activating a precautionary approach, the extent to which that was explicit in the decision making, although it was clearly there, as Professor Pollock pointed out.
I'm going to move to the next section of the panel's report now. Before I do so, is there anything further on the issue of the precautionary principle that anyone would wish to say? So the next part of the panel's report is entitled Government Decision Making and Implementation in Respect of Health Policy in the United Kingdom. And I'm going to direct this back to Lord Bichard, but again, welcoming contributions from all. Page 17 of the report, so if we could have the report back on screen, I think it's probably page 23 electronically, Lawrence. Thank you. You were asked to describe in broad terms the structures for the formulation of health policy in the UK. And I just wanted to pick up on what you say in the second paragraph about the role of the Department of Health and Social Care. Now, you're looking here at the current system as opposed to the position in the 1970s and 1980s. But you say this in relation to England. The Department of Health and Social Care still sits at the heart of health policy making in England. The department, on behalf of the Secretary of State for Health, is the only body with oversight of the whole English health and social care landscape and acts as a system steward, working to ensure its disparate parts function effectively to meet citizens' needs. It sets national priorities, and then there's reference to planning by NHS England, and creates and updates the policy and legislative frameworks within which the health system operates. Now, just before I then ask about what's then said about the position in the devolved nations, could you just expand upon this idea of system steward, Lord Bichard?
Well, I think it suggests that even now the department is at the centre, conducting, if you like, an orchestra, where other instruments are making a contribution. That's a really clumsy analogy. I've not worked in the Department of Health, so please bear that in mind. But in any department, you're looking at a situation where ministers are looking to experts beyond the civil service. They're looking at the civil service. They're actually looking at their special advisors. And in the DHSC, they're looking at NHS. And what they're trying to do, if they're to be effective, is to bring together all of that evidence, all of that knowledge, all of those contributions, And at the end of the day, the ministers have to make a decision. And that decision is often, as we were just saying, made in a world of uncertainty. I mean, all of our understanding in our society is imperfect. And evidence-based policy, for example, I've always thought was a slightly specious term in the sense that every policy decision we make is not evidence-based because we haven't got all the evidence. Some of it we don't even know about. But government ministers are sitting in the centre of this, and because of that, the department is sitting at the centre. It's acting as a conductor or as a system steward in the UK anyway.
And then it goes on to say a similar role is played by the health departments, or in Scotland's case, the health and social care directorates of each of the devolved nations. But with government more heavily involved in the management of the health services, there is more direct ministerial oversight, and the Director Generals of the Welsh Health Department and relevant Scottish directorates are also the chief executives of their respective health systems. Now, again, we'll pick up on that possibly again when we look at devolution at a later stage of the evidence. But Ms Salters, do you have any observations about, perhaps from a Northern Ireland perspective, about the extent to which this is an accurate description of the role of the Department of Health in Northern Ireland?
I would say it is an accurate description. There's more hands-on direct management from the central department. It's a smaller entity to manage, and the same is true as the report says in relation to Scotland and Wales. It's a very similar function, but with a bit more direct management.
And then just picking up towards the bottom of the page, now looking at some general issues in relation to policy making and not specifically limited to the Department of Health. The report says this: as with other areas of government, the priorities and policies that guide the system are arrived at through collaboration between ministers and officials, with input from relevant bodies, businesses, and sometimes members of the public. The process of policy development itself is typically imagined as a 6-point ROAMEF cycle set out in the Treasury's Green Book, and then we're told the acronym incorporates 6 stages: rationale, objectives, appraisal, monitoring, evaluating, and feedback. In reality, the process is rarely, if ever, this neat, but officials aim to cover each stage of the cycle at some point. I just wanted to ask, first of all, Lord Bishop, do you know the origin of this ROAMEF cycle? How long that's been in operation as a...
Well, I think something like it's been in operation for a long time, because I remember when I was in civil service back in 2000 that you were expected to have gone through this kind of rigorous process. I mean, as with all of these models, the reality is often very different, as we say in the report, from that. It's not as neat and it's not as rigorous as you'd like it to be. But I think in order to persuade the Treasury to support a policy or to put resources behind it, you were expected to be able to define, why you needed the policy, what the objectives of the policy were, and the other elements that we've touched on there. So it's been around for a long time. But I mean, these sorts of models have been around central and local government for 40 years or so.
And the Treasury Green Book is what?
The Treasury Green Book is the book which defines one of the things it defines is what you need to do to get support for policy or resources. Claire may be able to help me at this stage.
I suppose I would see it as the rule book that Treasury sets out for government departments wanting to get money out of the Treasury and then dealing properly with money when you've got it. It's the set of rules that the Treasury set down for managing governmental money.
May I ask a question? Just, I want to understand the ROMEF cycle, because it begins with the word rationale, which rather suggests that someone has already decided what policy they want to follow, and then they have the reason for it. Is the answer that this is actually the Treasury's Green Book? So a department has developed a policy which they think ought to be funded. It has funding consequences, and is persuading the Treasury to fund it, in which case you would have a rationale, objectives, etc., following on.
Well, I think, for me, the rationale element of this is explaining to those who have the resource and you're seeking investment from why you think this policy or this change of policy is necessary. And in order to do that effectively, you've obviously got to draw upon research evidence. You've got to draw upon your understanding of the environment out there. If you're going to persuade the Treasury to get to first base, which is there is some reason why we should seriously consider this policy.
So in terms of the policy development itself, rather than its funding, is it any different from the way in which we make decisions in management of our enterprises or our own personal life, which is you may wake up in the middle of the night and think, oh, I've got a bright idea, I'd like to do this, or I've done this but it doesn't work, so I'd like to try something else, or this is the evidence that I've got, these look like the possibilities, what I'd like to achieve is X, and this is the best way of doing it. I mean, how do you develop a policy at governmental level?
Well, I never found that going to the Treasury with a bright idea got me very far. So I needed to explain why this bright idea had traction. As I say, what's the problem we're trying to solve here? Have we got evidence to say that this is an issue which needs to be solved? Have we got enough here to persuade you to invest in this particular policy? Because if we haven't, we're not even going to get to second base. Or any of the rest of it. You need to put some evidence behind your bright idea. My point earlier was that because we live in an uncertain world and because we don't fully understand the world we live in, that evidence is never going to be kind of totally persuasive. You are working in a world of uncertainty, so you've got to make a case on that basis. I'm trying to think of a specific example from my own experience, but it doesn't come to me immediately. I think if I understand you right, what you are saying is that there is a danger that a department, for example, just believes that this is a policy they want to do, and therefore all they do is to justify the policy without actually thinking through whether the policy really is a priority, whether it really is needed. Sometimes even going to the extent of having pilots to prove that something should be done. I don't think that's the way that the system should operate. I think you've got to go before that and say, what's the problem here we're trying to solve? And why do we think that this project, this policy, is going to go some way towards solving it?
Professor Pollock wants to come in, but just before we go there, what you're describing is essentially, I think, a reactive approach, which says there's a problem here, how do we solve it? This is a way, etc.
As opposed to a proactive approach which would look like...
That's my question. I'm not providing an answer, but if you're thinking of how you're doing something which you're already doing quite well, let's suppose, how can you do it better? What about that?
Well, let me take a neutral example. Let me take an education example. I mean, if you're running the education department, if you're the permanent secretary, as I was of the education department, you should constantly be looking at the data you're getting from schools, for example. How are we doing in terms of numeracy and literacy? Going right back to the start of the Blair government, all the data told us we had a real problem. And that problem was not just evidenced by what was happening in English schools, it was evidenced by what was happening compared to other international systems. And we spent some time identifying what we thought were the best approaches to numeracy and literacy being adopted around the world. And we put all of that together and took it to the Treasury and said, look, you've got a real problem here. Kids are not leaving school numerate or literate. Something's got to be done about that. We think that this proposal will help address that, and we based our confidence on what's happening in Korea or Japan or wherever. And on that basis, we would like to engage with you in a discussion about resources and what the policy ultimately should look like. So it's no good just saying, thumb in the air. I think that, people are talking in the media about a problem in schools. You've got to go a lot further than that. I don't know whether that answers or goes some way towards answering your...
It goes some way.
Thank you.
Professor Pollock.
I was going to give an example drawing from 20 years of research experience of the Treasury Green Book and the Private Finance Initiative. So as you know, capital investment, which is also an issue for the Blood Inquiry, was a real issue for schools, courts, roads, prisons, hospitals. And basically, those who wanted to invest in new hospitals or schools were told there's no alternative for private finance, and so they were following the Treasury Green Book and appraisal system to make sure they came up with the right answer. But that was a policy that was predetermined, as it were.
Could I pick up on
Yes.
just when you were asking about proactive policy and so on? I think the majority of my experience within government has been, like Lord Bishard, sort of, here's a problem we want to solve, and this is our assessment of the best way to solve it. But there would also be other policies that would come in as manifesto commitments from an incoming government. This is the policy that incoming government has decided they want. And then there is the civil service assessment of what's the best way to deliver that policy, which is what the electorate has elected the government on. And so that would be your rationale going forward, that it's a manifesto commitment and this is the best assessment of how to deal with it. So in that sense, it's predetermined by what the public have voted for.
Thank you.
I mean, one of the, sorry to prolong this, but we go on, well, the report goes on to point out that that in itself is not enough. You need to be able to explain what your objectives are. And I would say, and always felt, that you should show how you're going to measure your success, how you're going to measure the objectives. And one of my criticisms of government policy generally is that often they don't build in to a policy how they're going to measure success. There's not the management information. I know it sounds very boring. The management information to show whether or not you are improving literacy and numeracy. And if you don't do that at the outset, it's very, very difficult to build it in later. It's very, very expensive to go around all the schools and say, now we want you to keep this information in a slightly different format so we can measure what success you're having. I think one of the criticisms I have about, I could go on forever about criticisms of the policy process, but one of the criticisms is we very rarely build in sufficient management information to be able to evaluate the success of the policy in real time so that you can then adjust it and amend it.
Yes.
Can I ask you to look again on this theme of how policies are made? At an Institute for Government report, RLIT 00001753, it's a report from Halsworth and Rutter, Making Policy Better, and if we go to page 9, please. We'll see the heading, executive summary, and then it says this: policy making is a core activity for Whitehall, yet despite improvements made under the last government, many ministers and civil servants are still dissatisfied with the way policy is made, and significant underlying weaknesses remain. And then if we go towards the bottom of the page, the last 3 paragraphs say this: what's striking about the current system is that no one in departments or at the centre of government has responsibility for ensuring that policy making is high quality and that the system responds effectively to ministers' priorities. We propose a series of measures to change this situation: the appointment within each department of a policy director who would report directly to the permanent secretary, work closely with private offices and act as the departmental head of the policy profession. They would coordinate policy work in the department. In particular, they would plan, commission and challenge internal policy work on behalf of ministers, review the current stock of policy and develop the department's policy capacity. Policy directors would also ensure that ministers are adequately engaged in the policy process. Was this an idea that was ever put into place, Lord Bishard, do you know?
I don't think specifically. I mean, I should point out I used to run the Institute for Government, and I think I was probably running it when this report was produced, so it's getting a touch incestuous here.
It's a 2011 report.
Sorry?
It's a 2011 report.
I think I just left. No, I don't think it was. I think there are some kind of underlying issues here, it always seemed to me that the policy process was inadequately scrutinised and challenged. And I felt, it's only a personal view, that someone like the National Audit Office could help with that. The National Audit Office is not allowed to look at individual policies for good reason, but it could look at how departments were set up to make policy, how effective their policy-making process was. So it's another way of challenging the process. That's never actually happened. The issue with the accounting officer is the accounting officer reports to the Public Accounts Committee and reports to the Public Accounts Committee on issues of value for money, probity. But again, because the Public Accounts Committee is briefed by the NAO, they don't get into the benefits or disadvantages of particular policy, because that goes to, the government role. Sorry.
Ms. Salter.
I was just going to say, I think there was some work done in government after this report to professionalise policy making and have, as part of a general process of having professional leads for the different professions within government, so the economist service, the finance professionals, HR professionals, and so on. Policy development was one of the hardest ones to professionalise, in part because the development of policy varies so much from department to department because it's subject specific, and the way in which you make policy, for instance, for health, is likely to be very different from the way in which you make policy for defence and so on. So whilst there was a head of profession for policy development, and there was an attempt to professionalise it, it was harder to do that on a cross-departmental basis than it was for some of the specialist functional leads, where there was a greater commonality of a approach across departments.
Yeah, I think that's a broader problem. Again, we could spend a lot of time talking about that. One of the failures of government is the inability to manage and plan and develop policy across departments. So having a policy director in one department is not necessarily going to ensure that your policy improves a great deal. In the better departments, with ministers who were really who really understood their role, a good minister can play the part of what's proposed here, the policy director, because they want to challenge policy. They want to make sure it's the highest quality. They want to make sure that it's going to deliver what it says it's going to deliver. They want to make sure it's of sufficient priority to put it forward to go into the legislative programme. So a good minister should be performing this role anyway.
But it may partly depend on whether you think, is policy a substance? Is it the reform of the health service? Is it the reform of the education service, and so on? Or is it a process of developing a thought process and then thinking through how you are going to deal with it? And if you have a different view about whether policy is, these are the things in the manifesto that we said we wanted to deliver, and are those being done, that's different from thinking, what is our process of developing policy, which I think is what this report is getting at, the process of developing policy, as opposed to the substance. And I suspect there's been a general mismatch in approach. The minister, as Lord Bishard is saying, is going to be coming at it from these are the policies I want to develop. Are they being developed properly and as I want them to be, as opposed to what's our analytical thought process to develop a policy as a sort of generic thing.
The idea that I was particularly interested in this paragraph is this idea of reviewing the current stock of policy. And the inquiry has been exploring with a number of witnesses, both ministerial and civil service, what happens when, not on issues that are manifesto commitments, but or have a clear party political element, but existing lines to take, existing policies that are essentially perpetuated year after year without anyone actually standing back and saying, this is the line to take for the last 4 years. Is it actually the right line to take? Was it based on a proper assessment, and should we now change? And we've had evidence referring to ideas of institutional inertia, to groupthink and institutional mindset. Are there any observations that the panel has in relation to those kind of issues?
Well, I very much agree that that's a problem. I think, again, good ministers will perform that role to some extent. Good permanent secretaries ought to be constantly checking that out. Are we asking the right question? Why are we just going forward all the time with the same policy delivered in the same way? So should the NAO. But basically in this country, we don't have a very powerful system of post-legislative scrutiny, which I think is a real hole. In other words, we pass legislation. Quite a lot of the legislation that's passed in this country is never implemented, but leaving that aside, what is implemented is not scrutinised sufficiently. And why isn't it? Because the government is so close to, if they're still in government, the policy that they don't actually want to have a critical appraisal of a piece of legislation they passed 2 years ago. So I think in all sorts of ways, some of which you described, some of which I described, I agree that we could be more rigorous in scrutinising not just the lines to take, but actual legislation, and constantly ask ourselves, is this working? Is it having the impact we want it to have? Do we have the management information to enable us to come to those conclusions?
I would completely agree with that. And I think looking at the lines to take, we could debate whether that's about reviewing policy or whether it's to do with the way we communicate publicly. I think there's insufficient scrutiny of that. It's partly a resource issue. Do you have enough people always to be reviewing everything to make sure that the lines are correct? Of course, you need to be able to do that. And I know most departments have, and I know the department I worked in for the majority of my career would have done that on a regular basis, whether we did it sufficiently frequently, and whether the people who were looking at the lines on a regular basis had sufficient overview always to understand the full context, as opposed to, well, that seemed to be right before.
And I think another,
Sorry,
another criticism you can make, the last one I'll make, is that in the whole of the discussion we've had in the last 15 minutes, no one's actually mentioned the public or citizens or people, and how you enable them to make an input on policy and what impact it's having and the reality of life. It's very easy in Whitehall and Westminster, as we all know, to become stuck in a bubble when you just play around in the bubble. I think that's hugely worrying, hugely damaging. I think citizens need to be involved at all stages of policy development and implementation and appraisal. And in terms of the context of this inquiry, that's patience. And I don't think we've got that anywhere near right, which brings us on to the issue of service design, which I'm sure you're going to come on to later.
So I note the time, so
Yes.
Perhaps a good moment for the afternoon break.
Yes, well, we'll take a break until 4:45. 4:45.